Hello, I'm Dr. Zheng from China. I'm the Vice Director of Beijing Anding Hospital, Capital Medical University. Today, I will give you a brief introduction to disruptive behavior disorders that includes oppositional defiant disorder, abbreviated as ODD, and conduct disorder, abbreviated as CD. Most of the content is based on the IACAPAP textbook. Now, let's take a look at oppositional defiant disorders first. ODD is a condition in which a child displays an ongoing pattern of uncooperative, defiant, hostile, and annoying behavior towards people in authority. The child behavior often disrupts normal daily activities, including activities within the family and at school. Symptoms are inappropriate to the child's comparable age and developmental stage and cause significantly impairment. The signs and symptoms of ODD include repeated temper tantrums, excessive arguing with adults, activity refuse to comply with requests and rules, deliberately trying to annoy or upset others, or being easily annoyed by others, blaming others for their own mistakes, having frequently outbursts of anger and resentment, being spiteful and seeking revenge, swearing or using obscene language, saying mean and hateful things when upset. The prevalence of ODD is 2 to 10%, and it affects boys more than girls. The prevalence peaks at 5 to 10 years of age and declines afterwards. The prevalence varies wildly across countries. This may implicate cultural differences in recognizing and assessing the severity of disruptive behaviors. The diagnosis of ODD is made clinically according to DSM-4. The child must manifest more than 4 of the symptoms listed in the previous slide, and the duration of symptoms must at least more than 6 months with significant impairment. Conduct disorder must be excluded before ODD is diagnosed. The relationship of ODD and CD or other mental disorders, particularly ADHD, are complicated. ODD is often seen with anxiety, depressive disorders, conduct disorders, ADHD, and substance abuse. Here are some clinical observations worth nothing. While ODD and CD has been found to have higher level of comorbidity, and the majority of children diagnosed with ODD does not go on to develop CD. Children with ADHD often develop ODD. Young adult depressions and anxiety disorders was often preceded by childhood ODD but not CD. No single cause of ODD has been identified. Genetic effects contribute significantly to the development of ODD. Many environmental factors, including family factors, contribute to the onset ODD. Maltreatment, negative parenting, lower socioeconomic neighborhood, and problematic peer influences are all associated with ODD. The diagnosis is made clinically. When conducting interviews for ODD children, try to obtain information from as many sources as possible. Assess comorbid psychiatric disorders such as mood disorders, ADHD, and CD. Assess other risk factors at family, school, and neighborhood. For example, academic difficulties, being bullied, etc. Most importantly, before labeling a child as having ODD, consider different diagnoses: ADHD, autism, etc. The center of ODD treatment is not medication. The first step is not identify possible comorbidities and treat them accordingly. Other treatable or modifiable risks should be addressed. Many intervention programs are available, including the parent manager training, such as Credible Years and Triple P. School-based interventions and individual therapy, for example, CBT-based anger management training. There is not evidence in the use of stimulants to treat ODD in children without ADHD. The prognosis of ADHD varies. The age of onset seems to be a good prognostic indicator. Childhood onset persistent group have been found to have poor adult outcomes when compared with no disordered and adolescent onset peers. The majority of ODD children will be symptoms-free with appropriate treatment. 30% of children with ODD go on to develop CD. The second part of this lecture is conduct disorder. Conduct disorder is a serious behavioral and emotional disorder that can occur in children and teens. Affected children may display a pattern of disruptive and violent behavior and have problems following rules. The disorder is long-lasting and can disrupt the child or family's everyday life. Overall, 2 to 8% of children are affected with a male predominance. 2 developmental subtypes have been identified. The life course persistent type is characterized by early onset of behavioral problems. Affected children often have comorbid ADHD and a family history of psychiatric disorders. The other subtype is adolescent limited. Affected children may not develop antisocial personality disorder, but can still suffer from social maladjustment. CT is also clinical diagnosis. There are 4 categories. The could be present in the child behavior, aggression to people and animals, destruction of property, deceitfulness or theft, and serious violence of rulers. It's important to exclude a substance-induced cause and instead address the substance use disorder prior to making a psychiatric diagnosis of conduct disorder. As is mentioned in the previous session, the relationship of CD, ODD, ADHD, and some other related mental disorders are complicated. Some are overlapping, others may have potential cause relations. ADHD, ASD, ODD, ASPD, and mood disorders are all potential differential diagnosis of CD. The clinician astute perception of symptoms and shrewd judgment is needed for the differentiation. The etiology of a CD is complicated and undetermined. Some risk factors are known to have causal effect on the onset of CD. These include genetic liability, possible candidate genes, MAOA, prenatal polymorphism, depressed mother and negative parenting, being maltreatment as a child, family poverty, and affiliating with delinquent peers. The path from childhood conduct disorder to poor adult outcome is neither inevitable nor linear. However, there are factors predicting a poor outcome. These factors are early onset of several problems, typically before 8. Several and frequent antisocial actors, having ADHD as a comorbidity, lower IQ, parental criminality or alcoholism, lower family income, and ineffective schooling. The treatment of CD requires experience and expertise. Some principles of treatment should be borne in mind. Engage the family for family therapy is the first-line treatment. Each context should be addressed, especially and hospitalization is rarely needed. Developmental strengths and promote learning for the children, emphasized on the positive instead of the negative. Comorbid conditions should be treated. The use of medications in non-ADHD children are controversial. There is only limited data on the treatment of risperidone and aripiprazole. That's the end of this lecture. Thank you for your attention.